Thank you very much. Assalamu alaikum, sabah al-khair jami'an. So my agenda for the talk, I'm just going to briefly discuss what is CTEPH, how is it diagnosed, what is the role of pulmonary angiogram, and then what are some of the available treatment options in real-life cases. So basically, CTEPH is a unique combination of two things. One, you get a PE, and then there is an unresolved clot which leads to mechanical obstruction. And through multiple different mechanisms, there is also an increase in a microvascular disease in even a non-obstructed area. And this leads to, both of these mechanisms leads to increased PVR and the dreadful RV dysfunction that happens later. So the epidemiology of CTEPH is somewhat confusing, and two reasons for this. Number one is, it's only about up to 5% of patients who have sustained PE that go on to develop CTEPH. Number two, a majority of patients with CTEPH, they don't recall a history of PE. So these two things make the diagnosis somewhat difficult and usually leads to delay in diagnosis and treatment. However, we should have, it is not recommended that we do screening for CTEPH in every single PE patient, but at the same time, we should have a very low threshold to do the diagnostic workup when there are symptomatic patients. So what are some of the risk factors for CTEPH? And we've seen before that large clots, it makes sense that large clot burden would lead to CTEPH in the future, but this has not been shown in trials. We know that some medical conditions like antiphospholipid represent about 10% of CTEPH cases. Patients with splenectomy, chronic inflammatory disorders, pacemakers are some of the patients that can have risk factors for these conditions. And so far, we do not have any evidence that thrombolytics or catheter-directed treatments lower the incidence of CTEPH in the future. So how do we diagnose it? So you have someone who had a history of PE or someone who is symptomatic with shortness of breath usually. You do an echocardiogram and you see an increased RV pressure. You go on, one of the diagnostic workup is to perform a lung scan, and this is very essential in the diagnostic workup. If that's positive, then you go to the next level and do a right heart cath to confirm the diagnosis, exclude other etiologies, and then go for treatment options. So we need, before we do the scan, we need at least 3 months of effective anticoagulation. And I will underline the word effective, because not every anticoagulation is truly effective anticoagulation. So after that, you should repeat the scan and ensure that the perfusion defects have not changed. And if that's the case and you have increased RV pressure, then you have your diagnosis. It is good to have that supplemented with other imaging findings like CT, MR, or pulmonary angiogram. We'll come to that. This is an example of a VQ scan, which shows you a normal scan in the left and someone with CTEPH where there's multiple mismatched perfusion defects at multiple segments of the lungs. So why do we still need the right heart cath? Because, echo has, it is not accurate in estimating the PA pressure. It does not give you any information about accurate PVR and cardiac output. The RV function is not very easy to assess. You really need a good assessment of the wedge pressure, and if this is supplemented with a pulmonary angiogram, you can also have information about the lesion location and operability in the future. So the newer hemodynamic definition of pulmonary hypertension is that you need a mean PA of more than 20. It used to be 25, not anymore. Wedge has to be less than 15, and a PVR is more than 2, not 3 like it was in the past. There is another entity which is called chronic thromboembolic pulmonary disease without pulmonary hypertension. So those are the patients that have perfusion defects, but they do not have the hemodynamic definition of pulmonary hypertension. And this is a group that is not very clear how do we deal with those patients. So when we do the right heart cath and we have the diagnosis established, it is always a good idea to supplement that with a pulmonary angiogram. And usually that's done through a IJ access, right? IJ access, 6 or 7 Frenches are enough. The ideal catheter would be a Berman catheter, but that's not, as far as I know, it's not widely available in the region. There's some shortage. And the reason for choosing this catheter is a balloon tipped, and it has multiple end holes before the balloon to allow for easier contrast ejection. It is always good to have a biplane to lower the radiation dose and also have the benefit of the lateral projections. Digital subtraction angiography is always good to give you more accurate assessment. You need a breath hold when you do that to have a clean, nice picture. So this is an example of a pristine pulmonary angiogram. You can see that's a Berman catheter in panel A. That's a lateral projection. Panel B is a frontal projection, and you can see the lobar, segmental, subsegmental, and even the smaller ones. And then in panel C, you also have to have time for the cine to allow you to see the venous retainer as well. This is an example of not so pristine angiogram. It's done with a pigtail catheter when there's a motion artifact, and you can compare it with the previous one to realize that it doesn't give you a lot of information. This is a selective angiogram, and it's usually done in the setting of balloon pulmonary angioplasty. And you can also play with the contrast dilution and also the frame rate, and it shows you different clarity. The pulmonary angiogram will tell you a lot about what type of lesion you're dealing with. You can have web lesions, CTOs, you can have complete obstruction, you can have multiple different lesions, and those lesions have different levels of difficulty when you're treating them with BPA, as we're going to see later. So now we've diagnosed the CTEPH. It is like many other cardiac conditions. It is not a single person show. It is a CTEPH team that includes a PH specialist, a PEA surgeon, a BPA interventionalist, and also a radiologist. The job of this team is to confirm the diagnosis, and probably the biggest job is to determine the operability and determine if BPA is a potential, and also whether or not medical treatment is appropriate. So this is how we treat CTEPH. This is the algorithm from the most recent European guidelines in 2022. So every patient should be on lifelong anticoagulation. And then once the team meets and discuss operability, if the patient is operable, then that's class 1A. If not, then we have two options, either medical therapy or balloon pulmonary angioplasty. So operability really depends on where is the location. So this is a very nice picture that depicts that CTEPH can be concentrated in one of multiple different levels. So if it is proximal, meaning main artery or lobar, then that's where PEA surgery is most beneficial. If it is mostly confined to the segmental, subsegmental levels, then BPA has a role. And if it's mostly at the microvascular distal level, then that's where medical therapy has the most benefit. I'll share the first case is a young guy who's a teacher, history of antiphospholipid syndrome on warfarin. He came in with worsening shortness of breath, echo showed high RVSP, not surprising that his VQ scan showed bilateral perfusion defects at the subsegmental and segmental levels. His right heart cath showed high mean PA pressure with a wedge of 9 and low cardiac output. So we don't have an easy access to a PA surgeon, so we started him on riociguat and macitentan. And I'm an interventional cardiologist, and I know exactly how it feels to open up an occluded artery in the middle of the night when someone comes in with STEMI. Such a pleasing feeling. However, receiving a message like this is even more pleasing. So basically, for those who do not read Arabic, he said, just a few weeks after starting the medication, he's back to 80% of his functional capacity. He used to have lots of symptoms, and not anymore. No more chest pain, dizziness, or cough. Very nice message to receive. So he went on to have the definitive treatment, which is PEA, and again, we sent him abroad for that. And it is the default that when a surgeon perform a PA, that they show you exactly what they achieve, what they extracted, because it really tells you how far did they go. And a surgeon that is comfortable and confident of his skills will show you where, like how far did they reach in the subsegmental levels. So PEA is a major surgery. It's a cardiopulmonary bypass surgery. It has to be done with a deep hypothermic circulatory arrest. And then there is a sequential right PA, left PA incisions to remove the organized clot. Usually if it's done correctly in an experienced hand, it can normalize PA pressures in majority of patients. However, this is not a surgery that you do once or twice a year. It has to be, like many other procedures, volume matters. So the expert center has been defined as a center that performs high volume, more than 50 cases a year, with a mortality of less than 3%, and the ability to reach the segmental levels. Unfortunately, PA is not always successful. Some patients, they're not eligible for surgery due to different reasons. Some of them, they have significant pH, residual pH, and a lot of them also have recurrence. So that's why we have to also explore other options. So another example here is a 54-year-old lady with morbid obesity, PE a few years ago. She had the same diagnosis. She declined invasive therapy, so we only had to stick with medical therapy. Those are the medical therapy pathways for PAH. The ones that are approved for CTEPH are Rio-Ciguat, which is works in the nitric oxide pathway and has been shown to improve outcomes in patients with CTEPH, not operable. And again, a very pleasing message to receive that she felt much, much better after starting the medical therapy. Last but not least, there's balloon pulmonary angioplasty, and I think the best person to talk about this is Dr. Ali. He has a wealth of experience in this procedure, but basically it's a procedure that started in Japan in the early 2000s, and they pioneered and improved the procedure. The learning curve has gone way long, and now we have good studies that show good hemodynamic outcomes and lower complications. The most important complication would be reperfusion, pulmonary edema, and also perforation of the pulmonary arteries with the wires. So this is an example of a CTO where, again, you use multiple different techniques. A lot of them are similar to what we use in the coronary trees. You can also do things like kissing balloons, but again, there's no stenting in this procedure. You go with ballooning only, and the reason for that is, I'll show you in a second, but basically BPA is a multidisciplinary approach. You have to do the procedure multiple times, targeting different areas each session, because you want to reduce the incidence of pulmonary edema, reperfusion pulmonary edema, so you need multiple sessions to target the different vessels. And the reason we don't stent is because it's completely different than coronary artery disease. The problem here is, if I can show that last slide, please.
Can we have 2 minutes, please?
So basically, this is an OCT of a patient with CTEPH, and you can appreciate the webs that are because of the organized clot. The media is intact, and when you go and disrupt these webs with a balloon, the risk of restenosis is very minimal, and that's why you don't really need a stent for those type of problems. So basically, CTEPH is a disease of a lumen, not a disease of the vessel wall, and we try to just break those webs and maintain the media without any dissection with an undersized balloon. So that's basically the principle of this procedure. I think with that, I would like to conclude, and thank you very much.